grand facade so soon will burn without a noise, without my pride. I reach out from the inside. In your eyes, the light, the heat, I am complete. See the doorway, the thousand churches, the resolution of all the fruitless searches. Oh, I see the light and the heat. Oh, I wanna be that complete. I wanna touch the light, the heat I see in your eyes.
Welcome, everyone. The webinar will begin shortly and will be recorded. Wanted to thank you all for all of your responses in the Mentimeter. I feel like we got a lot of great responses. I just wanted to invite you all to connect with the campaign for grade level reading on social media. On Facebook, like the page Campaign for GLR, and on Twitter, follow the account at Reading by Third. Please use hashtag Learning Tuesdays and tag us to tweet anything you learned from today's webinar, and we'll be sure to retweet. We encourage you to share your questions, reflections, and observations on social media. Okay, once again, welcome to today's conversation. My name is Sierra Sanchez, and I'll be behind the scenes helping to produce this webinar. I have just a few housekeeping details before we get started. First, we would love for you to introduce yourself, so please use the chat box at the bottom of the screen to share your name, city, or state, and your organization. Be sure when responding to select both panelists and attendees so that we all know who is here. The webinar is being recorded, and a link to the recording will be emailed on Friday to all who registered. And all resources that you see shared as links in the chat will be compiled and shared in a follow-up email to all webinar registrants. Lastly, we'll be posting a brief on-screen evaluation during closing and highly encourage you to respond. This helps us with our commitment to continuous improvement. Lastly, before we begin, I would just like to call your attention to our upcoming GLR Learning Tuesdays webinars. Later today at 3 p.m., we will be having a session on a reprise session of Learning at Home and at School Public Media Education Partnerships. We'll be closing off the year of 2021 with a funder-to-funder conversation. With a learning loss series on New Jersey tutoring core lessons and accelerating learning. And we'll be bringing in the new year with these sessions listed above. Information and registration for these sessions and more will be posted in the chat box. Joining you now is Sarah Torian, Senior Consultant with the Campaign for Grade Level Reading. Thank you and enjoy the webinar.
Thank you, Sierra, and welcome everyone. Thank you all for joining us for today's Funder to Funder conversation entitled Community Investments in Parent-Child Relationships Drive School Readiness. This session is all about relationships, connections, and feelings. So I appreciate everyone's engagement in our opening exercise today, sharing how you are feeling in the chat box and listening to a little Peter Gabriel as he reminds us about the power of relationships, of eye contact and engagement. That's really at the heart of early relational health, those healthy, nurturing, warm, and responsive early relationships between an infant and their parent or caregiver. These relationships support healthy and positive child development, feelings of trust and social connectedness that benefit both the child and the caregiver. These relationships and connections help promote the social emotional development that is a key developmental foundation to school readiness, supporting both language and literacy development and future academic success. Right now, only about 50% of children are kindergarten ready when they arrive at school, while 1 in 6 children ages 6 to 17 has a treatable mental health disorder, and 1 in 7 new mothers experience paternal depression and anxiety. More can be done to support young children and their parents and caregivers to nurture early relational health, including increasing access to paid family leave, something that only 20% of private sector and 26% of state and local government employees have access to right now. And there is much that funders can do to increase the protective factors and reduce risk factors as a mechanism for promoting early relational health and preparing young children for success in school and beyond. In today's conversation, we're going to hear about a number of ways in which funders are doing just that. And to begin that conversation, I am honored to welcome and introduce our panel for today. First, I'm delighted to welcome Brenda Blasingame. Brenda joined the J.B. and M.K. Pritzker Family Foundation in 2020 as a program officer on the Pritzker Children's Initiative, where her work is focused on strategy development in the areas of child well-being and child welfare prevention, work with and in Latinx and Native American communities, lived experience and parent community leadership in justice, equity, diversity, and inclusion efforts. Welcome, Brenda. Next, I'd like to welcome Mel Brennan. Mel is the CEO of United Way of Southern Maryland and has led for 2 decades in impact nonprofit organizations, delivered social change events, and informed social and governance change movements. He previously played a lead role in Thread Inc. in Baltimore, a strategy that harnesses the power of relationships to create a new social fabric of diverse individuals deeply engaged with young people. So welcome, Mel. Welcome also to Ira Hillman. Ira leads Einhorn Collaborative's bonding strategy, supporting collectives of funders and programs nationwide that help parents and their babies establish and maintain emotional connection from birth. Ira also played a lead role in conceiving and planning today's conversation. So thank you for that and welcome, Ira. Next up, I'm delighted to welcome Renee Nogales. As program officer at the Burke Foundation, Renee manages a growing portfolio of maternal and child health grants in New Jersey. She guides the grantee identification, review, and evaluation processes and partners with the foundation's leadership to ensure that it invests its resources into programs and policies that will have the highest positive impact on New Jersey's children and families. Welcome, Renee. And last, but certainly not least, is Dr. David Willis. David serves as Senior Fellow at the Center for the Study of Social Policy and is a national expert in pediatrics, early childhood systems, early relational health, and early childhood mental health. At CSSP, he helps to advance the growing intersection of child health transformation and early childhood system building with a social justice emphasis and an early relational health frame. He is a leading expert in this field, and we are absolutely delighted to have him with us today. So welcome, David. Before we get started with today's conversation, we'd like to get a sense of who is in the room with us today. And for that, yes, I'd like to launch a quick poll. Want to get a sense of not only who's in the room, but also what is your level of engagement and efforts around early relational health. So we've launched this poll. We'll wait just a few moments to give everybody a chance to respond, and then we'll move on. Oh, wow, the responses are flowing in now, so we'll wait just a couple seconds more. All right, great. It looks like quite a few people are supporting parental engagement and support, lots focusing on early care and learning approaches, as well as pediatric approaches like Reach Out and Read, some home visiting, and also several folks who are not yet engaged or supporting work around early relational health, but are interested in learning more so that they can get engaged. That's wonderful. We hope that we can help you with that today. So Ira, before I pass the mic over to you to moderate today's conversation, I'd like to ask a few quick questions about the work that you are doing in this area. So to set the table for today's conversation, can you just share with us why early relational health and positive parent-child relationships are such an important piece of the work of the Einhorn Collaborative?
Great, Sarah. Well, thank you for having me today. I'm so great to be among good friends and all these panelists. I see how people are excited. I also see how people are exhausted and tired. It's that time of year. So I want to acknowledge that before we jump in. At Einhorn Collaborative, we seek to address the crisis of connection that we're facing in this country. It's part of why I think many of us are exhausted and tired. We've been through a period the last several years, it's gotten even worse through the pandemic, of increased isolation and loneliness in this country, as well as the increased division and polarization that we're seeing. And in order to really address this crisis of connection, which is imperative because in a diverse democracy, we need to be able to build across our differences, build relationships across difference to solve problems in this country. That begins with healthy, positive relationships. And the best place to start that is early in life. The relationships we have as babies with our parents and caregivers sets the stage for the relationships that we have throughout our lives. When parents are responsive and sensitive to the needs of their kids, the babies learn that the relationships can be mutual and reciprocal, and that together, collectively, we can address the needs that we have, and that sets the stage for us to be able to solve the problems and address this crisis of connection. That's why we invest in early relational health, so more parents and more kids experience emotional connection more often.
That's wonderful. So what barriers do you see that hinder or prevent these positive early relationships that are so foundational, as you're saying? And how are you working to address those barriers?
So I think it's important when we talk about barriers that the good news is we don't believe that there's a barrier to connection from the start. Actually, babies in utero, through their physical connection with a pregnant parent and pregnancy, are already connected. There is co-regulation, there is mutuality and reciprocity going on between that baby and child, the baby and parent in utero. The challenge comes from the disconnects that are inevitable in our lives. Beginning with childbirth, doctors take the baby and run all these tests. The parent and child are disconnected. Parents return to work, children go off to school. So the barrier we have to look at is how do we repair and rebuild that connection when we have those moments of disconnect? And what is it that actually begins connection? Well, Sarah, when I call your name, you reacted, you smiled, you oriented to me. Orienting is what begins that repair and reconnection. But orienting can be hard because we have so many distractions in our lives. And those distractions are so much greater for families experiencing stress and trauma. For the communities that we're all talking about today, many of you are focused on communities where stresses and traumas relate to poverty, racism, adverse childhood experiences. So we wanted to look at how could we overcome some of those barriers and actually begin the orienting that begins that process of reconnection. And so we studied a different area where there was stress and trauma, and that's the NICU, the neonatal intensive care unit, where parents and kids who are born prematurely spend a lot of time there. And this is actually a problem for many more families in this country than we might think. 1 in 10 births are premature, so 10% of families are experiencing the stress and trauma of premature birth. And so these families in particular were also having trouble orienting to their kids and the kids orienting to them. The kids are covered in an isolette, covered in wires. The parents are grieving the fact that the birth did not go the way they planned. What was the tool to overcome that barrier? Emotional expression. When through the intervention that was tested through the Nurture Science program at Columbia University, parents were encouraged to tell emotional stories to their kids. The emotional story of this birth that was not what they planned brought up lots of emotions, but also a simple prompt like tell your child how you chose the name for them. And what we saw is suddenly these kids, these little babies, too small to talk or do anything, turned their heads up to look at the mom as the mom spoke, because this emotional expression brought that about. And this resulted in benefits for both the children and the parents. The children, we saw increased brain development at term age, and at 18 months age, decreased behavioral problems, and other kinds of issues that appear on child development screens at 18 months, and reduce depression and anxiety for the mothers. So there was mutuality of this. And so a barrier that I see also is how we're going to change practice in pediatrics, healthcare, elsewhere to focus on relationships, not just on the child. But I will encourage us as we go off to spend time with our families, try out these emotional prompts and see if you tell the story to your kid about how you chose your kid's name, I think you will all get more connected and you'll see it in action.
I love that. So what investments, what does it look like? What are your investments in this area?
So our investments for the last decade and a half were really around this research, wanting to understand how could we overcome this disconnect through emotional expression. So we learned that. We also, through the work that was done through researchers at Columbia, they developed a quick observational tool that in the course of 2 minutes, a parent-facing professional can observe the parent-child relationship and the interaction at play and figure out what kind of supports can be provided. So they're looking at some of the things that we had in that moment when you oriented with me, Sarah, the facial communication, our vocal communication, eye contact, the give and take that you have once you orient and then connect, and then figuring out how to support that more deeply. So now we want to move into a place where we want to really change the mindsets, because I said that's the barrier that now needs to be removed, is how do we change the mindsets in parent-facing settings to focus on the relationship, not just the child. And in order to do mindset shift, that's a collaborative effort, because you need all the players at the table to make sure that the systems transformation occurs the way you want. So the first collaborative that we're an anchor funder for is a new collaborative housed at the Center for the Study of Social Policy under the leadership of Dr. David Willis and the Early Relational Health Coordinating Center there. And we're going to take this science out into practice and say, how could we co-develop with families, with clinicians, training of healthcare professionals and other parent-facing professionals around early relational health? What does it take to remove the barriers in family-facing organizations so we could actually embed an early relational health approach? And we believe that over the next 5 years, by working with partners, I see many folks from Reach Out and Read are on the call. Reach Out and Read has already been piloting some of this training. You'll hear from a pediatrician later in our session about this work. We believe in the next 5 years, we can build an evidence base to show that this works in real life to get changes at the American Academy of Pediatrics. We're focusing on pediatrics because it's a universal, non-stigmatizing touch point in the early years of life. But I do want to say the other investment we have is in the Pediatrics Supporting Parents Funder Collaborative, which we'll be announcing just next month, hopefully, 5 communities where we'll be showing how this takes hold in pediatrics, but then moves beyond that through a public health approach to lift up early relational health throughout a community. And so across this work, I think we're going to take a grass tops approach to changing leadership and practice change, but we're also going to actually see it on the ground in communities and with a demand from families to make the change that we want. So all of our early childhood systems embrace early relational health.
Thank you. I am so excited to see how that evolves and unfolds. So I'm going to pass the mic over to you. And now I'm excited to learn from Dr. Willis and the other the funders on the panel. Thank you.
Great. Well, I'm going to start in conversation with Dr. David Willis, who I'm going to call Dave, because as I said, we've been working together and collaborating on this work deeply for the last 1.5 years now, but I've had the pleasure of learning from Dave since we first met about 5 years ago. And I'm excited today for you all to learn from him as well. As we begin, before we move into the funder conversation, let's root ourselves in the science of early relational health. So Dave, I know you come to this work as a pediatrician with more than 30 years experience as a clinician, focused both on early childhood development, but also experience in family therapy. So share with all of us what early relational health is and what it looks like.
Ira, it's great to be with you. And gosh, you sound like a pediatrician more and more all the time as you talk about emotional connection, which has been the core of my interest of all the years that I was in primary care pediatrics, then developmental pediatrics, doing a lot of family therapy and connecting with families. I've dedicated my career to learning about how do we ensure the health and developmental well-being of every child. And of course, I followed closely the science, that core story of child development, not only building from what we learned about brain architecture, but all that now talks about children develop in that environment of relationships. That's come to be a core understanding in early childhood and also in child health. early relationships really matter. Early relationships shape the health and well-being of the child and the caregiver and are key for social-emotional development. A group of us began to focus on calling this early relational health, which describes the positive, nurturing relationship to advance physical health development, social well-being, and resiliency. Early relational health drives health and developmental outcomes. Those relationships are critical. Early relational health may be a new term to some of you, but it's not a new field. It really is built on the decades of research from fields of child development, infant mental health, neurodevelopment, but it focuses on elevating the centrality and the criticalness of relationships between caregivers and young children, bringing that into the experience of child health with all families, in public health, in all efforts of when we partner with families. Hence, it's two generational, it's multi-generational, it's cultural, it's deeply connected in all that we matter. But amazingly, as Ira alluded to, early relational health is easily observable in the first years and these patterns. And I want to show you a little video so you can get a sense of that. Feast your eyes on this cute, wonderful, emergent relationship of relational health. Let's run the video for a moment. That's not the right one.
Hello,
I want to show you a little baby and her mother. Not it either. There we go. So feast your eyes.
Uh-oh.
You're in that relationship. Okay, you can pause the video and put it back down. Thank you. So what you witnessed was early relational health, an emotional connection, those observable elements. And now in science, we know we call that actually autonomic emotional connection. Observable indicators that come out of the natural science program and Martha Welch's work about with the WEX, where we can actually see mutual attraction, mutual vocal expression, mutual facial expression, and reciprocity, mutual reciprocity. Those elements are observable. We can teach them. They can become a part of and are becoming a part of what is the new pediatrics moving forward. So Ira, back to you.
You've shown me that video before, but every time I can't help but smile, and I feel it. I feel it in my gut. I feel that connection that they're having. That's terrific. So what changes are you seeing? You've been at this for decades, but in the last several years, I know you've been doing a lot of work around this. What changes are you seeing around a growing awareness of the importance of safe, stable, and nurturing relationships, which are the foundation of early relational health? Where's the momentum?
Oh my gosh, Ira, it has never been better. And in a number of ways, let me just highlight a few. One, Reach Out and Read, in its 30th year celebration, acknowledged that they were adopting their next chapter activity of efforts to advance early relational health as foundational for early learning and literacy, recognizing that relational health drives future literacy, education, readiness. Now we're working intimately with them. We've already activated the interest to reach out and read physicians across the nation. Many of the affiliates are increasingly interested. I've had the chance of presenting to many who are saying this is really an important movement going forward, and the work with Einhorn that we're doing with Reach Out and Read to create training around those emotional connections we were just talking about is moving forward. Secondly, we've learned, however, that it's critical that we bring an anti-racist and equity frame in this work. We've got to have relationships that are meaningful, trusted, and valuable, co-developed with families. And that equity movement around early relational health is likewise building. But I would say to you, what's most exciting is in August of this year, the AAP put out a new policy statement called Preventing Childhood Toxic Stress, Partnering with Families and Communities to Promote Relational Health. All of the early childhood committees within the AAP, including its board, had to approve the release of this policy. And its first statement says, and I quote, listen, by focusing on safe, stable, and nurturing relationships that buffer adversity and build resilience, pediatric care is on the cusp of a paradigm shift that will reprioritize clinical activities, rewrite research agendas, and realign our collective advocacy. We've come of age. Here we are. We have much to do. And as my dear friend Andy Garner says, you know, beyond trauma-informed systems and beyond just age screening identification, and even beyond promoting positive childhood experiences, we now know preventing toxic stress and promoting early relational health are two sides of the same coin. So Ira, the future of pediatrics is about early relational health, and it's about transforming front-facing early childhood systems, public health, and communities, all focused on advancing the strong, important, critical emotional connection for all families and children. My last comment is an emotional connection is only a state of the relationship. It is always modifiable and strengthening and repairable. There's always the opportunity to build strength and early strong relationships to counter the social emotional challenges we have with children, the mental health challenges we have with children, focusing intentionally on building strong, connected, repaired emotional connection is critical for the future here. So it's a very, very critically exciting time. So Ira, back to you.
Yeah, no, terrific. Well, thank you for helping us see what this looks like, and then helping us understand that it's actionable and that the time for action has never been better, given that AAP statement just a few months ago and everything else that is happening. I'm going to take a moment now to invite all of I think we've got 100 plus folks now on the call with us today, to take a moment to reflect about perhaps a moment of early connection that you had with your child or from your own early childhood with a parent or caregiver. Would love to hear in the chat box an example of what that looks like, that memory of that connection might look like. And even if you don't want to share what that actual connection moment was, what did it feel like? I told you the feelings that I had just watching that young baby interact with the mom. What are the feelings that you have when you have connection with a loved one, a child, a parent, someone else who you love in your life? What does that look like? Please share in the chat. Make sure it goes out to everyone. Pure joy, Allison, right? It's something you feel. Hope, right? There's opportunity for change, safety. This is what it's about. And I think as I hear those words and say those words, I'm feeling those because our bodies have been trained to understand what this feels like. And there's real power in this. And so we're going to share with you, we've got some pre-recorded sessions from some experts in the field that are going to help us really understand the power of these relationships and the love, admiration, peace, and contentment that they can drive. Thank you all for sharing so much. So I'm going to tee up our first expert champion, really, somebody who's really a champion early relational health. Dr. Kate Rosenblum is a scientist and practitioner, and she's going to describe for us her research findings that demonstrate the power of an early relational health intervention in a home visiting context. And I saw in the prior survey, there's a good number of you who are working in home visiting, so I think you'll be particularly interested in this. But she talks particularly about how this work gets at ameliorating some of the effects of trauma and stress that have been passed down from generations, and particularly around some outcomes that I think will be of interest to those of you who are focused on grade level reading, because they specifically relate to language development. And the last thing I'll say is Kate comes at this from an infant mental health background, which I know some of you on the call probably share. So I think you'll be interested from that perspective. So let's hear from Dr. Kate Rosenblum.
Hello, I'm Kate Rosenblum, and I'm pleased to be here today to share with you some work around how relational health in the early years can promote health and well-being in young children. 1 in 4 infants across the nation is experiencing economic oppression, and the stress of this for families can be carried across generations. As a scientist and a practitioner, I've dedicated my life to understanding the science of early relationships and how intervention can promote, nurture, and restore relational health to promote positive outcomes over generations. My work is deeply informed by infant mental health principles and practices. I'm the board president for the Alliance for the Advancement for Infant Mental Health, and I'm also the PI on a series of studies examining the impact of Michigan's model of infant mental health home visiting. Across all of this work, I focus on dyadic relational processes, that is the dance between infants and parents, as this dance, the science tells us, lays a critical foundation for young children's well-being and capacity to achieve their full developmental potential. What's more, early relational health is modifiable. That is, we can nurture and support early relationships. So today I want to illustrate with some of our work how early relational health can be promoted and the impact that can have across generations. So the Michigan Infant Mental Health Home Visiting Model is a needs-driven and relationally focused home visiting program. It's Medicaid funded and widely scaled across the state of Michigan, serving families from prenatally through first 3 years. And our initial work was really focused on understanding whether the infant mental health home visiting model impacted the key outcomes that we thought it should. What we found was that indeed home visiting had a positive impact on key critical indicators, including things like parental responsiveness and infant social emotional well-being. Importantly, we conducted this study in the real world setting with providers who were delivering this in the community. And so these findings were very encouraging. So many of our interventions start in the petri dish of a university-based environment, but here we had a widely scaled, broadly implemented intervention in the community that was having critical impacts for families. So our next step was a randomized controlled trial to really understand how this might work and to be able to look at questions of causality. So we randomly assigned parents either to a home visiting intervention group or to a treatment as usual control group. Families in this study were at elevated risk either because of having experienced adverse childhood experiences of their own or due to their sort of mental health symptoms in the present. What we found was exciting. Whereas at study entry, there was an association between parent mental health and early relational health. Over time, this relationship was fully mitigated by participation in home visiting services. So let me show you here. What you can see here is that in the no treatment control group, what you can see is that as parent PTSD symptoms increased, relational health decreased over time. But in contrast, for those families assigned to the home visiting program, there was no association, as you can see in the red line here, between parental PTSD and relational health. So what does that mean? Said differently, home visiting interrupted the intergenerational transmission of risk and eliminated that association between post-traumatic stress and later infant relational health. Truly, early prior experience for the parents was not destiny. But that wasn't all. In a recently published paper, my colleague, Jessica Riggs, and I demonstrated that the infant mental health home visiting program impacted not only relational health, but other critical domains. We know from a large number of studies that there's critical importance of infant toddler language development. And indeed, it's a key predictor of young children's school readiness. In our study, as in so many others, we demonstrated that at baseline, there was a strong association between parental adverse childhood experiences and child language. But similarly to the results that I presented earlier, participation in home visiting fully interrupted these effects. That is, for those who received home visiting, there was no association between caregivers' ACEs and their child's language development 1 year later. I find this to be profound. A relationally focused intervention can impact more than just relational outcomes. Indeed, as relationships serve a critical foundation for young children, we saw that it could also promote other indicators of health and resilience, including language development. It's not only early adversity that matters, but relational processes, relational health that can predict well-being and resilience for young children over time. And so fundamentally, altogether, these results really underscore the ways that early relationships truly are foundational. Thank you.
Wow. So, I talked earlier about the NICU, 1 out of 10 kids, and the adversity that we saw there, and how early relational health intervention there could help interrupt the transfer of stress and trauma and the effects on the child. And then here we see in a home visiting context, the broader impact of early relational health on the broader stresses that come about through ACEs. And so it's just so encouraging to see multiple areas of research, particularly Kate's that was out in real life settings, not in the Petri dish as she described in academic research. How can we move this even further out into universal settings like pediatrics through programs like Reach Out and Read? Again, I see you all. I see you today on the call. So let's hear next from Dr. Usha Ramachandran. She's a practicing pediatrician who is affiliated with Reach Out and Read, and she's going to describe her experience, which she found to be transformative, where she participated in a pilot of using a lens of emotional connection, that observational tool I described earlier, in her well child visits. So this was in the course of a short interaction, the 15-minute well child visits that we're familiar with. And she talks about how this new focus on the dyad not only changed how she practices medicine now, but it also really changed the relationships she has with her families. So let's hear now from Dr. Usha Ramachandran.
Hi, I'm Usha Ramachandran. I'm a general pediatrician, and I provide primary care to pediatric patients at a federally qualified center in New Jersey. I have also been providing Reach Out and Read during well child visits at this health center for close to 2 decades. When I heard about the initiative from Reach Out and Read to create or develop training for pediatric clinicians on observing and supporting emotional connection between parents and their young children, I was really excited to participate because through the course of my work with children and families, it has become increasingly clear to me that emotional connection that kids have with their parents in the very early years forms the foundation for everything else that comes after that. I was also really impressed with the thoughtful approach that Reach Out and Read took with this initiative. Instead of throwing experts at us to tell us what to do, they put together a learning collaborative with pediatricians such as myself, nurse practitioners, family medicine doctors, and most importantly, parents. So we all met as a group several times during the course of 6 months, and we were taught at the very beginning how to use Martha Welch's WEX Emotional Connection Screen. And then we went off to our sites and we started to try to use the WEX during well child visits at our sites. And I have to admit that at the very beginning, I had my doubts. I was like, am I going to really be able to do this in the setting of a busy well child visit? And are parents going to sort of feel uncomfortable if I did this and so on? But as I started to try it, more and more, the more I did it, the easier it got and the more natural it started to feel. And I realized that it really didn't add a whole lot of time to my well visit. And it sort of felt natural and moved with the flow of the visit. Sometimes I'd walk in the room and the parent and child would already be face to face, mom's cooing, mom's talking, baby's cooing, and all the elements of connection and the WEX were happening right there. And I would just take time to sort of recognize this, compliment mom on this, talk about how important this emotional connection is, and then I would just move on to the rest of the visit. Sometimes, of course, I would have to prompt the mom a little bit to create that moment of connection there in that well-child visit. For example, I'm thinking about this one mother where I told her, like we were taught to do, to talk about an emotional topic with her child. So I said to her, can you talk to your baby about why you chose her name? As it turned out, the baby was apparently named after that mother's favorite aunt who had passed away recently. So when the mother started to talk about that, that emotional connection just happened. The baby kind of turned to the mom, and that reciprocal emotional connection just happened. And it was such a beautiful moment, both for me as a witness and for the mom. You know, it's just great to see that, you know, that aha moment in parents when that connection happens. And it's such a great way to segue into conversations about why that's important and what are some things that parents can do at home to, you know, to strengthen and support that connection. And of course, there are times when that moment of connection just doesn't happen during the well visit. And then I remind myself that this emotional connection is a state, not a trait. And so I am not really making judgments about the parent-child relationship or anything. I am just observing that this might be a family that might need a little extra support in this area. And now I have the tools to be able to have a conversation with that parent about what they might do at home to strengthen that emotional connection. So it has just completely transformed the way that I practice pediatrics. I can't imagine not doing this with my young pediatric patients anymore. And I wish that I had known some of this when my sons were younger. So as we sort of all got comfortable using the WEX in our office settings, and we, you know, came back and discussed best practices, Reach Out and Read has been able to put together training based on our experiences on for pediatric clinicians on how to use a WEX lens to observe and support emotional connection between parents and their young children. We are getting ready to pilot this training at 3 different sites in New Jersey. The sites vary widely in terms of their patient populations, in terms of their socioeconomic, racial, and ethnic diversity. And the providers are not part of the team that created the curriculum at all. And so it'll be really interesting to get their opinions on this whole, the training, as well as the process of using the WEX lens and so on. We will be doing detailed qualitative interviews with both the providers and, most importantly, with the parents to get their opinions, perspectives, and how it felt like being on the other side of that interaction. What worked, what didn't work, how could we do this better? And then everything that we learn from both the parents and the providers will be fed back into the training. And then we will tweak the training if necessary, and then spread it across the other, the Reach Out and Read network of 100 sites in New Jersey, thousands across the country, and then continue to study the feasibility, acceptability, and impact of the training. Thank you.
Well, thank you to Usha and to Kate for allowing us to use these videos again to help us all understand the real potential of what's possible around early relational health. You can see the traction that's coming in the scientific and research community, as well as the program and platforms that are out there, like Reach Out and Read and all the other programs that many of you are funding and supporting in your communities. So let's talk more about that with my funder colleagues. I want to engage them and hear from them about the work that's going on in the communities they're supporting, the kind of work they're funding, and then we'll open up soon after this to conversations with all of you. But first, let me bring on my peer panelists, Brenda, Mel, and Renee. Please go ahead and turn on so everyone can see that you're going to be part of the conversation. I'm so honored to be in conversation with all of you. What a perfect way for to be able to end the year and move into this period of rest and renewal, to be learning together with all of you. I'm looking forward to it. So we'll start off with just a question for each of you to get for you to help introduce yourselves to the community here. Let's start with Brenda. I know the Pritzker Children's Initiative is working with communities around the country. My guess is that Many of the 100 participants we've got on the line are probably doing work in some of those communities, as well as many other communities. Tell us how early relational health is reflected in your work, especially at this community level.
So it's so interesting, Ira. We are working in 20 states and 10 communities across the country. So I know there are people out there that are part of a state where prenatal to 3 is being lifted up. Our focus is prenatal to 3 every day, every minute, and unapologetically. We're centering justice and equity in our work in those partnerships. There are 3 pillars to our work, and I think people are going to start to see that there's a theme as we all talk around the work we're doing. Healthy beginnings, which is prenatal, period, birth, postpartum, supported families, and access to high quality early care and education. It's during these first 1,000 days that we think we have this amazing opportunity around early relational health in the work that we're doing. And I chose this slide as the slide to center my comments on because I think we're learning so much more from science and research now than we knew 5, 10, 15, 20 years ago. And we can see through this slide from the Harvard Center for the Developing Child how everything is interdependent and totally connected to the other things. And so how we think about what we're doing in those 3 pillars is that we have to be moving to do all the things for this supportive relationship. And so that means that we have to be really addressing the issues that bring stress into the lives of parents and families of young children. And that we have to be working on developing those core skills, which are actually our executive functioning skills, and how important that is, that this is where that starts to develop. And so it develops between parents and children, and the parents are actually imparting those core skills through that relationship that they have, through that meaningful, supportive relationship. And so we're centering all of our work completely around making sure that the practices and policies that are going on are all about reducing the challenges and barriers and uplifting all these other pieces so that parents can do the job of being their child's first and most important teacher.
Beautiful, Brenda, thanks. Renee, let's turn to you next. The Burke Foundation is working at the state level in New Jersey specifically. So tell us what your investments are around early relational health and also how that work has evolved over the last several years.
Well, first of all, thanks to the campaign for hosting this important and timely discussion. I'm really excited to be here with all of you. The Burke Foundation is a private grant maker that began in 1989. We've always been interested in helping under-resourced children and families thrive. But a little over 4 years ago, the foundation launched a strategic planning effort to find out which programs would have the greatest impact. And the team conducted a research scan and talked to dozens of thought leaders and doers that resulted in a report of funding recommendations. And not surprisingly, it made the case for investing in the early years. Out of that process came our 3 pillars, investing in enhanced prenatal and postnatal care, such as community doulas, programs that promote nurturing relationships between children and caregivers, and advancing access to quality childcare. Now, another aha moment from that research was that if Burke wanted to make a real difference for young kids and families, we were really going to need to address ACEs. Our president, James Burke, was inspired by Dr. Nadine Burke Harris's TED Talk, invited her to come to New Jersey with our partners and be a keynote speaker at an ACEs symposium. Burke ended up joining a couple of other private funders, the Nicholson Foundation and Turl Fund, along with the New Jersey Department of Children and Families, to form the New Jersey ACEs Collaborative. So this group has launched several initiatives, such as a statewide public awareness campaign about ACEs and what adults can do to mitigate the impacts of trauma. Now, all of this is incredibly important work, and Burke came to really appreciate the importance of not losing sight of lifting up an asset-best framework. So instead of talking about ACEs, we're really framing it as positive childhood experiences, feeling safe and protected at home, having at least one nurturing caregiver to really help counteract early adversity and foster resilience. And Burke really owes a tremendous credit to Dr. Willis and Ira for helping us reframe our thinking. Next slide. And to that end, we're investing in upstream prevention, programs that increase protective factors as early as possible. I'm just gonna, in the interest of time, I'm just gonna focus on a couple right now. One is Healthy Steps. This is adding a child development specialist, often a licensed social worker, to the pediatric care team to deliver wraparound supports and warm referrals for families. And we're co-funding a Healthy Steps pilot that includes sustainability efforts to hopefully scale it in New Jersey. And another project that we're supporting is with the New Jersey chapter of the American Academy of Pediatrics to implement Keystones of Development. This is a curriculum that was developed by the Mount Sinai Parenting Center. And what drew us to this work was we were pretty surprised to learn that most graduating pediatric residents didn't feel comfortable talking about child development because there's very little of it focused on in medical school. So Keystones is really meant to fill that gap by teaching residents how to promote healthy brain development during well-child visits. NJAP has introduced it to all 9 pediatric residency programs, and they're now piloting it with family medicine as well. And I'll just briefly mention we're doing a parent video series also with Mount Sinai that will be integrated into well-child visits.
Thank you, Renee. Well, now let's turn to Mel. Mel, your work has been focused on the power of relationships for quite a while now, back to your work at the YMCA and with Thread Incorporated all in Baltimore. Share a little bit with us about the power of relationships at the community and family level from your perspective, and now how that's now influencing your work at United Way of Southern Maryland.
Thanks, Ira. Well, I'm similarly pleased to be here, pleased to learn, pleased to share. So thank you for this forum. In some ways, this is simple and straightforward. We can look almost 4 years ago at the statement, white paper, policy paper from the National Academy of Medicine, which really leans into this idea that context matters, right? And that children's development is best promoted when we pay attention to context and make sure that the context around young people and not just their individuation is strong and is healthy. They also lay out the context of children being embedded in families and families embedded in communities. But what's interesting across my work, next slide, please, with many nonprofits and now with United Way, is that there's also another cultural context that weighs heavily on relationship building, made up of a few things. But I'll discuss 2 of them very quickly. One is proximity, and the other is our, really across the country, a little bit of a hyper commitment to life as a perfectly individual project, right? And our resultant distance with those 2 things from individuals not only tracks with our own empathy, but our commitment to nuance, to systemic responses and searches for root cause. Next slide. So, when we think about individuals that we see on our streets in increasing numbers today, we very often have distance from those individuals. So we very often lack nuance. Very often we'll have stereotypical responses like get a job. Next slide. But, when those same struggles manifest in our own families, it's complicated. Right? It's replete with nuance. It's replete with not only the choices that individuals make, but also the dependent context in which they sit and have sat. So when we lean into the individual, distant, individualist cultural take on societal outcomes generally, and in regard with what happens to communities and families in particular, the power of relationships can be diminished. How do we change that? How do we subvert that in healthy relationship building? And gird the power of relationships. Next slide, please. Well, with renewed cultural consciousness and with renewed practice and the sociological definition of culture, right? Daily ways of life. But all of our society building tools tell us this is an interdependent reality, right? And it's going to force new thinking upon us and our systems, that we have to hold 2 ideas in our mind equally at the same time, both that things are replete with an individual context and a dependent one. Both, always, all the time. All of our scholarly disciplines and rigorous theory tell us this, right? But it also is, it's empathic within us. We get it, mirror neurons, right? We connect, but it's also anecdotal. You can't go down the street. You can't get through traffic lest you have an interdependent relationship. It's your choices and everyone else's that will move us through traffic quickly, right? So these practices also manifest in the real world and our anecdotal sensibilities. And it necessitates a rejecting of that cultural context and developing more complete language, ideas, and practices. Next slide, please. How does that impact families and communities directly? Well, when we do that, right, we move from seeing families and communities as made up of individuals and see ourselves as inextricably linked. I'd ask the group today to think about a new term, intervidual, right? Imagine yourself as an individual, right? You're both all of your individual will, skill, choices, and practice, but you are also inextricably linked with everyone else everywhere else. We're individuals, right? And when we can do that type of thing, when we can build grammar and language and vocabulary and practice that reflects both of those things, we solve more effectively for the gamut of interconnected issues that we do have, right? When we have that consciousness, then we can have a different set of practices at powerful leading edge nonprofits like Thread, but also with our agencies in United Way. We know what authentic, powerful relationship building looks like. Next slide, if you would, please. It begins with that authentic connection. We can't have it without that new consciousness, right? But that authentic connection really does matter. And then once you're authentically connected, we can set mutual goals, right? And individual goals, and then overcome the barriers to those goals, and then rinse and repeat that process as a way of seeing and being in the world. So that is what our agencies are head down doing. We'll talk a little bit more about that later, but at the United Way of Southern Maryland, that's our lens on the issue.
Okay, well, thank you, Mel, Renee, and Brenda for those great kicking us off with these remarks. And now let's move into some questions that we thought would be of interest to everybody on the call today that I'd love to hear responses from each of you. So the first is, what are you hearing from families in the communities in which you're working with regards to early relational health? How is what you're hearing from families influencing the work that you're doing? And let's start with Renee on that one.
Yeah, I wanted to highlight a project that we're supporting through Reach Out and Read New Jersey, and that's what Dr. Ramachandran talked about earlier. It's part of a multi-state effort. And the input of families has really been critical to designing this training. And New Jersey conducted 7 focus groups with families, and just wanted to share some learnings from those. First, caregivers shared what they see as the key elements to having a great relationship with their kid. And these probably won't be a surprise to you all. Communication, and that goes beyond verbal. So it's skin to skin, physical touch, snuggling. Comfort, creating a space where kids see their parents as sources of safety and love. And time, and this goes beyond quantity. It's also about really giving one's full attention and really being present to make the most of the time together. Then parents were asked if they ever talked with their child's doctor or nurse about what it's like to care for their baby. And they were actually really open to having these conversations and to talk about these topics. But in most cases, they really struggled to see it happening. Appointments were rushed. They only focused on the physical health, or the clinicians barely interacted with the child on a personal level. So it really felt very impersonal to many of the parents. One parent said, I don't know when family medicine became factory medicine. But despite this, there is hope because the docs that are testing out this content, they're finding that families are very receptive and resonating with the content, as Dr. Ramachandran described earlier in the video. And the one other thing I just wanted to highlight is, parents had some ideas on how to promote early relational health, not only within the family, but with the family. First and foremost, providers have to build trust. And they had some tips on how providers could do that. So the first is to really take the time to get to know families on a human level, engage with the child, ask the parents how they're doing, and really mean it. Second, engage in all levels of staff on how to model relational health with families. That starts with the front desk and the waiting room. And finally, don't forget the dads. There were many reflections that observed that, sometimes the docs will only pose questions to the moms, even though the dads are standing right there in the room too. And just to wrap up, we've actually heard this quote before, but I love it. I think it's a great example of how easy it is to start building a connection with a family during that first well-child visit.
Appreciating the shout out to the dads as a 2-dad family myself. And I'm going to pass it on to another dad, Mel, to add your remarks on this subject.
I'm excited to be a dad. I just want to hang out in the shout out. No, but we're hearing a lot of things from families and communities with regard to this stuff. And a couple of things really quick are the impact of allostatic load is one thing that we're hearing from families. And if you don't know the term, it refers to the cumulative burden of chronic stress and life events. And Dr. Rosenblum, in her video earlier, spoke to this in terms of specific ERH impacts. But when environmental challenges exceed our ability to cope, then allostatic overload ensues. And families are telling us that that's what they're experiencing right now. So it's across this crisis, but we'll talk a little bit more about how this has been more than that. We're seeing chronic, allostatic load is very often called the silent murderer, because it really is when you're seeing this growth in the rate of chronic disease, of stress-related chronic impacts. That's what this is about. And families in general, parents and children, are letting us know daily that what everyone is feeling now across the pandemic, racial reckoning and other crises, social isolation, environmental imposition, reflects the singular long emergency they've been in for some time, right? And so what's powerful about this moment is that everyone who's experienced some of this now has an intimate relationship with what families in crisis are experiencing all the time. Another way in which United Way very quickly understands this is through our ALICE lens. ALICE is an acronym at United Way, and it stands for Asset Limited, Income Constrained, and Employed, right? So it's the group that isn't in persistent poverty per se in terms of the digits and the numbers, has a job, but really is one incident, one stimulus, one problem away from being in ongoing crisis, right? So asset limited, income constrained, yet employed. And I think I forgot to give this to Sarah, but I'll put it in the chat here, which is United Way's ALICE analysis across COVID-19. But we're finding ALICE families are 39% of all families and households in Maryland, for example. So close to 4 out of 10 families are at or below the ALICE threshold, right? One thing takes them into crisis. And they're reporting permanent disruption from childcare, school, university closures, health and safety issues for unsupervised children, loss of free and reduced breakfast and lunch. And underreported is the 25% of ALICE families reporting inadequate internet access, right? So that compromises the ability for e-learning, signing up for certain things, gaining access to information in a timely manner. We can't over-report enough that just because it seems like internet access is ubiquitous, it really is not. It really remains a divider of access for families and children.
Thank you, Mel. Brenda, what are you hearing from families in the communities where you're working?
So I am going to approach this with a slightly different angle because we are working nationally as a foundation. We're not specifically working in a state or a specific community. And I want to talk about, if we can go to the next slide, I want to talk about the work that we've been doing with the Rapid EC project. The Rapid EC project has been hearing from families in what is as close as we can probably get to real time about their experiences during our pandemic that we've been in. And this is going to touch on several things that Mel has said, I think. What we're hearing is that families are going through extreme hardships. And Mel was right on point. Like, these are not hardships that weren't there before, but they're hardships that are exacerbated and pronounced right now. And you can see in these two slides, I chose the two slides that focus on well-being for children and well-being for parents, because the well-being of parents is directly connected to the well-being of children. So again, we are in this place of talking about the interdependence of what we're doing. And as you can see on the right-hand side of each one of these is the beginning of the pandemic and where people started, where people came in. And that's the lowest point. And as you can see over the last 2 years, the level that has happened for parents in terms of their well-being, looking at issues of stress, loneliness, anxiety, and depression. Those 4 things, you can see how that's just risen during this period of time, and it's stayed elevated. And for children, this is looking at, are children internalizing or externalizing their symptoms? And you can see that it has risen during the pandemic, and it has in fact stayed at a very high level. So from all this information that we've been gathering, what we know is that we have to address the financial and material resources that families have. We have to look at what we often call the social determinants, which are the conditions that have been created as a result of the intersection of systemic and institutional racism and poverty, when those 2 things come together. That families want safe housing, healthy food, access to healthcare, and other necessities that they know are critical to their being able to promote the health and well-being of their children. So we come out of this with 4 key things that we know families have been saying through this process, through Rapid EC, that aren't just about the moment that we're in right now. They're about the moment that we're in now and the moment we were in before. So what we're hearing, of course, is the financial stability and the relief from material hardship, being able to have that basic income to cover all of your basic needs. What we're also hearing from families is they want access to integrated child and family services to promote health, behavioral health, housing, and education, all those things. They don't want to have to go to 5 or 10 different places to get that. This gets back to what Renee's talking about. In most of the states and communities we're working with, there's some kind of navigation system that's being set up, a point of entry that's about connecting families and their children to all the services and all the supports that they need. They want adequate emotional support, both from formal and from informal approaches. So formal would be thinking about what's happening in childcare and through home visitation that's also already been brought up here. Informal is about family, friends, and their community members. It is about creating community and connections and networks. Again, all of those things are relational for families. They want to have those connections. And then finally, but certainly not least, is families are saying that they want time, right? And that is so critical to this time to focus on health and well-being. And that time turns into things like paid sick leave and personal time. It turns into paid vacation time. It turns into maternity and paternity leave. So that in this early stage during the first 1,000 days that we're specifically focused on, that they have the ability to do all the things that they need to do to create this space that is a safe, stable, nurturing environment and have that early relationship that's reciprocal and connected and looks like what we saw in that video.
Well, thanks, Brenda, for sharing all that information. Thank you also, Mel and Renee. I think, it's important that we listen to all these. The families are the know, right? And it's what I talked about at the beginning. As I said, connection's already innate. It's all the systems and these other things that Brenda just talked about and others have talked about that get in the way. But there's a real opportunity. We heard from Dr. Ramachandran about what this might look like in a pediatrician's office. I'd love to hear from others about what other systems and portals you're looking at to promote positive early relationships and early relational health. And let's start with Brenda. We'll start with you this time.
Yeah, so we are very focused on, as I said earlier, we're how we're centering racial justice and social equity in our work is very important to us. So the pathway that we're most interested in starting with is the pathway that's community-based. And so what we are beginning to do and just starting, I'm super excited about this. It gives me an opportunity to work with David Willis some more, which is looking at how we make that connection through community-based doula services or community-based perinatal services. A lot of what many places are doing to combat issues around equity in terms of birthing for Brown and Black women is to have community-based doulas or community-based perinatal workers that may be peer support breastfeeding specialists that come in and work with families. So we are focused on how do we embed early relational health into the system that already exists. So we are just getting ready to fund in the new year a partnership between the Center for the Study of Social Policy and Health Connect One, which is the premier national program for community-based doulas, also directly connected to work that's going on in New Jersey. You may have seen their little logo down there and all of that work that's happening. And they are going to build a curriculum together for early relational health and embed it into the work of community-based perinatal health workers. I'm so excited because, as you know, the community-based approach to looking at community health workers is really about getting to that sweet spot of cultural, linguistic, and racial concordance. It's folks that are hired and trained from the community who are trusted in the community and can make those relationships that we know that are authentic and trusting, where parents will listen and share and confide in around all the different issues that they're facing as they're bringing their newborn home and going through this whole process of the first 1,000 years.
Well, I share your excitement about the launch of that work. I can't wait to learn from it. I think it'll inform the work that is happening in the pediatric reach out and read work that's happening and vice versa. So I'm excited that there'll be some bidirectional learning. Renee, you were invoked by Brenda with the Health Connect One connection. So let's go to you next.
Thanks. Yeah, very excited about this work as well. I'd like to share two examples. First, we just launched in partnership with the Department of Children and Families, a pilot of Family Connects. This is the first universal home visiting program in New Jersey. Every family having a baby at the county birthing hospital is invited to enroll. And if they do, they'll get 1 to 3 home visits from a registered nurse starting about 3 weeks after they deliver. And during the visit, a nurse conducts a health assessment on the birthing individual and baby, including a screening for postpartum depression, and also does a social needs assessment of the entire household and makes warm referrals to resources that are tailored to their needs, like food, childcare, lactation support. And as you all know, this is a time that when the family is adapting to many changes and are likely facing many stressors, regardless of income. So, one component of Family Connects is really that it's aiming to help reduce stress and strengthen supports for families as much as possible so that those foundational relationships can take root. And I'm excited that running in parallel to this, earlier this year, that Governor Murphy announced that New Jersey will become only the second state after Oregon to launch a statewide universal newborn home visiting program. Burke has identified this as one of our core strategies and will be involved in a marketing and communications campaign to encourage service uptick and also helping to build a nurse pipeline. The second example is centering parenting. This is still in the healthcare system, but it's not healthcare as many of you all may think of it. This started as a 2-year pilot with the Department of Health and a couple of other private funders. And now Burke hopes to help transform the healthcare landscape by expanding centering to 50 sites over 5 years. For those of you who don't know, this is a relationship-based group healthcare model that incorporates peer learning, community building, and social supports to improve the health and well-being of moms, babies, and families. It brings pregnant women, or in this case, families, out of the exam room into a comfortable group setting with their healthcare team for about an hour and a half or 2-hour sessions. This is a photo of a centering parenting group, and there's always time set aside to meet individually with the healthcare provider. But what I think is so powerful about the centering model is that it's really a chance to share experiences and learn from one another. It recognizes the strength that each family brings into the room, and it's a chance to create connections within families, between families, and with healthcare providers.
Thanks for that, Renee. Mel, what other systems and portals are you guys looking at?
Well, you're going to hear some overlap, Ira, and I think that that's right. What some of the things that Brenda and Renee have emphasized with regard to home visitation, for example, and the importance of that as an opportunity is reflected in how I would answer this question. Agencies and partnerships matter for us, right? Whether the partnership is municipal and nonprofit, like something like Be More for Healthy Babies, which was the city of Baltimore recognizing that they had a racial delta in infant mortality that was unacceptable, and addressing that directly and partnering with nonprofits to do it. Or it's, Food Works, the program at the Maryland Food Bank, which is focused on workforce development and family resources, and recognizing that stable employment girds a whole other set of issues for children and families. But at the United Way of Southern Maryland, we engage 76 agencies, right? From HIPPY, which is a home visitation pathway that can begin prenatally to support parents and having the knowledge and actionable skills to prepare their own children for success, to Health Share and Center for Children, who are laser focused on getting medical care and mental health care, which is under supported and undergirded, to families and children who don't have typified access to it, to entities like Children's Aid Society, which proffers a physical space and place for the promotion of well-being through those material physical goods that produce well-being, like diapers, right? And the cost thereof. I'm especially fond of Children's Aid Society, as my own adoption as a child was facilitated by the Children's Aid Society in Philadelphia. It's self-supported by United Way. It's literally part of the reason I'm here. But again, these groups have been here. And it's our job to recognize how head down they are doing the work and get them the resources that they need to do it more completely and effectively. And in the case of United Way, playing our role in connecting them in an integrated way to those agencies that can and do help, so that we can say, hey, we already know that not being able to pay your utility bill is the second leading reason why people become homeless, right? So we're going to help get you the resources to pay your utility bill so that you can stay in the house, because a house without heat means that children's Child Protective Services needs to come in and engage that family now, right? So we have line of sight with that 11,000 foot view that we can not only make sure that they're connected there, but they're connected with 5 other agencies that reflect the nucleus of resources that are required to make sure that families survive, then thrive.
Well, all of you lifted up, these agencies and programs that already exist and are ready to embrace a focus on early relational health. They just need our support. You've already lifted up the fact that families value this, but also need our support. So, why isn't it happening already? What are the barriers that are getting in the way? And let's see if we can quickly do a quick go round before we move to any other Q&A from our participants. But what are the barriers that you're seeing, and perhaps strategies that you're exploring to address those barriers? Let's start with Mel and then work around to Brenda and then Renee. Mel, you're on mute.
That's the key phrase of 2021 into 2022. You're on mute.
Right. It's now an official Zoom meeting because we have that, right? Now we can count it as official.
We talked a little earlier about this cultural context and the cultural perception of the individual project when the reality is interdependent. But I want to talk also a little bit about power, right? One of the things that we need to pay attention to is recognizing that there are different forms of power, visible, hidden, and invisible, and to work to make visible power something that is discussed and negotiated, to make hidden power visible and invisible power subverted. So, sometimes when you go to the doctor, the visible power is in the mandates that the doctor is aware of. The hidden power is the decision-making process that led to those mandates. And the invisible power is sometimes how we just cede the authority to the doctor instead of having an expert partner relationship with the doctor, right? Same thing might happen for you at the DMV, right? The DMV has rules those rules come from somewhere, this black box that we don't know about, and we see power to that invisibly. We need to subvert all those forms of power in order to get at something that Dr. David talked about very early on, which is an anti-racist and more equitable framework from the very beginning of this conversation. Because that's where all the places where we can't see, where we can't engage, is where all the nonfeasance and malfeasance and the things we want to fix about our society are taking place. It's also bias, right, is a barrier. Explicit and implicit bias that leads to prejudice, right? And prejudice, I define very simply as the ability to be stone cold ignorant to someone else's truth, right? So it's not only historic bias and prejudice like racism that we have, but I walk around with able-bodied privilege, right? And prejudice, right? I'm able to walk around every day not really thinking about what it takes to get on the metro or the New York City subway when you don't have the same ability that I have. And so we've got to subvert that by being conscious of it, raising it as issues. And then I want to talk a little bit very quickly about fragility. And it's not just the narrow fragility that we've seen historically in the scholarship that talks about unmarried versus married households and them being fragile. It's actually the fragility that we're seeing in measures like ALICE, which have more of an equity lens, right? The fragility in being one incident or stimulus away from deep crisis, right? And if you go to the next slide, what I would argue, and what we argue at United Way, is that the opposite of fragile isn't perfect resilience per se, right? It isn't becoming situationally bulletproof to everything that comes across your table, right? It's being anti-fragile as a usable form of resilience. Anti-fragile is this idea that everything educates, and that it provides an opportunity to refine or revisit practices, systems, and intended outcomes, right? It's an approach that demands that we use this moment that we're in to build out ourselves in such a way that we have an agility for the next thing, which we know is coming, but we don't know what it is, right? But we can imagine that there's another crisis on the horizon. How do we use this moment to build out mechanisms, interconnection, relationships, and systems so that we're strengthened to be responsive, right? And so those three areas are areas in which I would see as barriers. The last slide I have here talks a little bit, next slide, please, talks a little bit about strategies. And again, the overlap, you've heard from a couple of panelists already, the idea of trust, right? When trust gets down on the ground with individuals and with communities and with families, it's about three things. It's about competence. Are you actually competent at what you're talking about and what you're doing and what you're sharing? Sincerity. Are you authentic in the way that you want to connect and your commitment to others? And are you reliable? Whether that reliability is once every year or once every day, whatever you've determined your reliability to be, are you that? That's where trust actually comes from, right? It comes from those three things. And when we have those three things in surplus, then we have the platform to engage in other ways. Another strategy for overcoming barriers is to pause for the cause, right? This idea of seeking the root cause of issues and engaging that first. If we can engage that, then the energy we might spend on 15 other ancillary issues is really concentrated on the main issue that's causing the 15 other issues. So really paying attention to root cause matters. And then if you ever heard of that Eisenhower decision matrix, which has important and urgent on two axes, we want to be high and to the right and agree on what's both important and urgent and engage that first as well.
Thanks, Mel. Brenda, and then Renee, what else would you like to add in terms of barriers and ways we're addressing them?
If we could go to the next slide. What I want to say about barriers is really about our fragmented systems, our marginalization of certain communities, the systemic racism and poverty, and very importantly, the mental models and narratives that people with power hold about certain other groups of people, who's deserving and who's not. I want to say that one of the things that I think we can do to address the barriers and what we're exploring is what you see in front of you. There's a prenatal to 3 policy center that has been established, and they have created prenatal to 3 state policy roadmaps for every single state. And when you look at this, again, you're going to see the interdependence. You're going to see that the third space over that column is actually about nurturing the relationships that we've been talking about. And so it's about policies and practices. That's where we have to start focusing our work. We have to change what the system is, because the system does what it's supposed to do right now. It doesn't help everybody. We've got to make it so we're centering families, we're centering parents, and that we're being anti-racist. Not that we're just dismantling, but we're actively anti-racist, and we're putting in place the policies and the practices that will get us to where we are trying to get, not only around early relational health, but about health and well-being of children during their first 1,000 days.
Great. Renee?
Yeah, rather than directly address barriers, I just want to note that we're very much in learning mode. Burke is always in learning mode. And so earlier this year, we tapped Dr. Junlei Lee to lead an early relational health field scan that will really help us go deeper in this area and help us identify other strategies that we can invest in. He's a child development expert who used to co-direct the Fred Rogers Center for Early Learning in Children's Media. His research focuses on understanding and supporting the work of helpers. So those are the folks who serve children and families across a number of sectors, and working in orphanages, schools, and youth programs from North America to China. He helped develop Simple Interactions, which is a tool that encourages and celebrates adult-child interactions and the power of everyday face-to-face moments. So you can read the goals of the scan, but what I will note is that the results will be unveiled at the inaugural Early Relational Health Summit in New Jersey that we're co-hosting with NJP and the Department of Children and Families. The summit will gather a wide range of stakeholders, but I think we're most excited that families will be there. We'll be talking about the latest research and promising innovations both in New Jersey and nationally. And we're really looking to get the insights of parents and caregivers of what they think of early relational health and include their ideas on potential action items. And I think the culminating deliverable will really be an early relational health call to action that will be for all relevant stakeholders to help amplify and take early relational health into to the next level.
Great. Well, Renee, Brenda, Mel, thank you for this beautiful conversation, enhancing my learning, making me look forward to 2022 and all the possibilities that lie ahead. Dave, thank you for continuing to be my teacher in the practice and science of early relational health. And thank you, Sarah, for letting me steal your thunder and lead the middle of this whole conversation. I'm going to pass it back to you, Sarah, but really grateful to the Campaign for Grade Level Reading for giving us the chance to lift up this important work around early relational health and hopefully engage more funders in this type of work as we move it forward in the year ahead.
Ira, I welcome you to steal my thunder any day. This has been an amazing conversation. I just want to point out, we just posted the evaluation poll that was mentioned at the opening, and I would encourage everyone to take a quick moment to share your thoughts and feedback through that before we close. It really helps us with our commitment to continuous improvement, and we want to hear from you about how well these sessions are meeting your needs. We only have just a couple of minutes more, but we were just talking about policy efforts, and we got a question posted in the chat box asking for advice around what funders can do to advance policies. And I know the Burke Foundation has had a lot of success recently in the state of New Jersey, and Pritzker, you were just sharing that policy roadmap. Brenda and Mel, you were talking about Alice and the way that United Way is working to reduce some of these stressors for families. Any advice that you all would offer to the funders on the call today about opportunities for advancing policy and practice changes that can really create the space and potential for stronger early relational health?
Yeah, one of the tacit, maybe we underemphasized tools of Alice, and I think Brenda's prenatal to 3 policy impact center is that we give information based upon where you come from. So when you're talking about policy change, you have to address the concerns of policymakers, and policymakers come from a certain place. They represent a certain constituency. And if they can take your data and understand it through the lens of that constituency. So there's an Alice report nationally, and then there's an Alice report for Maryland, and then there's an Alice report for the counties in Maryland, right? So that everybody at every level can take that content and do something with it. And I'm seeing, Brenda, you could speak to this, the same thing with Prenatal to 3 Policy Impact Center. I was able to go on and see what Maryland is supposed to be doing, right? And so I think that's one of the mechanisms funders can use, is to articulate the data that they generate, or the partnerships that generate information that they have, and make sure that it's really accessible through the lens of policymakers.
Let me just speak as a national funder. I think one of the things that especially local funders like Renee, that are funding in a state or funding specific communities, is to explore who's working on prenatal to 3 issues in your state or community. And then especially if it's one of the 20 Pritzker states that have established a collaborative for prenatal to 3, then how can you bring more local funding to that work that is happening? And how can you support that connection of community to state work and state back to community? And how can you support and champion in your states and the communities you're funding in, centering lived experience and centering parents in leadership, and embedding that throughout your systems in your states and communities?
Yeah, I'll just quickly add, I mean, not everyone is lucky to have, you know, a First Lady Tammy Murphy who champions all of these issues. It definitely makes our work a lot easier. But I would say, you know, to Brenda's point, that, you know, anything that can be done to convene voices, whether, I mean, I know that, you know, sponsoring a forum and things like that, it's a lot of work, but really to bring the different stakeholders together, and as much as possible to amplify the voices of the people on the ground who are most affected. You know, I used to do advocacy work for other programs before I joined Burke, and my favorite day going to the state capitol was bringing families with me, because then I just had to get out of the way and just let them talk. And it was awesome. So I would say amplify the voices of the families, and that'll really help.
And Sarah, if I can, I just want to quickly
Yes.
put in a pitch for, on the policy side, a key piece of policy is Medicaid and CHIP financing. Since so many babies born in this country, that's where their health coverage comes from. And the Pediatric Supporting Parents Funder Collaborative, I think our website was posted in the chat previously. Some of the support that we did in the first few years supported the Center for the Study of Social Policy and Manat Health to create this Medicaid CHIP blueprint for how you could leverage already existing Medicaid policy and CHIP policy to better support social emotional development and early relational health in your state. And so states can take advantage of that blueprint. We had a multi-state work group that we supported, but then we heard from other states that weren't even part of that work group. We said, we read that blueprint, we used it to figure out how to change the policy. And there's a companion guide also that CSSP created around Title V MCHB funds and how they can better work with Medicaid to support this work. So there are tools out there, and I think all the other opportunities that we've heard about today that folks can take a look at to get going.
Thank you for that. Such actionable advice and tools. Really appreciate it. Just a huge thank you to our entire panel, to Ira Hillman for helping to organize and bring this amazing panel together, to Renee Nogales, to Brenda Blasingame, Mel Brennan, and of course to David Willis as well for sharing that research and the background on this important topic. Thank you all for joining us, and thank you to everyone who's joined and listened in today and learned with us. I don't know, this time of year, I feel like it's all about family relationships and connections. And this has me just so excited to go home with my children and see my father and other family members. Really appropriate time for this. I'd encourage everyone who's listening in to tune in for future sessions. We've got another session this afternoon. Focused on, it's a reprise of a session that we did in partnership with the Public Broadcasting Service about how to support learning at home as well as in school through partnerships with PBS. And then we've got two more reprise sessions, one next Tuesday, another Funder to Funder conversation that's looking again at New Jersey, Go Jersey. I'm in New Jersey. At the summer tutoring corps that the Overdeck Foundation and the New Jersey Pandemic Relief Fund sponsored this summer, and how it's continuing, and the roles that funders can play in advancing high dosage tutoring as an equitable learning recovery strategy. And then another session focused on teacher staffing shortages and how there's policies, opportunities, and innovations to support substitute teachers and also address the teacher staffing shortage. And then more sessions coming in 2022. I got that right. Thank you so much, everyone, again for attending. Thank you to our panel, and have a happy New Year and happy holiday season to everyone. Take care.
Thank you.
Thanks, everyone.
Thank you.